Hello, everyone. My name is Christy Amobi. I'm with Xstrahl. It's a pleasure to be with you here today. This is part of a mini series that we have been working on with Dr. Jason Beckta, who is also here today to answer your questions. I'll go over a little bit more information about the mini series in just a bit. For those of you who registered early, you did receive a message from me with a question form. So we do have a few questions that have already been submitted that we'll go ahead and kick off today's session with. Also, I just wanted to note, again, on behalf of Xstrahl, thank you, Dr. Beckta, for this content. If you haven't had an opportunity to listen to the podcast series, please make sure to go ahead and do that after this event. We did strongly recommend that you would listen to all of the episodes prior to attending so that you would be able to get most out of this question and answer period. And last but not least, the entire session will be devoted to questions. So for the next 40 minutes or so, we will be answering the questions that you have about the content that Dr. Beckta covered in the mini-series. So I'd like to go ahead and just as a reminder of the content that's included in the podcast. This is Dr. Beckta's podcast. It's called Out of the Basement. You can find it on Spotify, on Apple, kind of wherever you get your podcasts. The topics covered, it's several series, several episodes, if you will. Dr. Beckta covers the history of low-dose radiation therapy, talks a lot about radiophobia, the risk of secondary malignancies. There's an entire episode devoted to how to get your first patient, set up treatment planning. There's another episode which covers coding and billing in the United States. Again, that's at a general level. There are lots of differences in the way that treatments are reimbursed according to what state you're living in, et cetera. And the last episode, which just dropped this week, was episode 4, part 1, which covered evidence and Dr. Beckta's view around some of the randomized control studies that have been done on this particular topic. And also, as a epilogue, if you will, to this session, Dr. Beckta will be recording one kind of final thoughts episode to conclude the mini-series. So again, thank you so much for doing this, great clinical education content, Dr. Beckta. So without further ado, now I'll get going on the questions. Okay. First question, is there any evidence for using low-dose radiation therapy for other types of arthritis, such as rheumatoid arthritis, seronegative or psoriatic arthritis? Is the protocol the same for these?
That was pretty good. That I sometimes think that they intentionally make all medical words very difficult to pronounce, so we all just stumble over them because it's funny for somebody back in history. So I think this is probably the most, I don't even know if I could say the most common question that I could say that definitively, but I hear this quite a bit. And so, the answer I usually give and how I usually practice in real life is no and yes. So if somebody is recently diagnosed or newly diagnosed with something like rheumatoid arthritis or psoriatic arthritis, I usually don't offer this or don't even bring it up. So, because it's, as I've discovered in doing this, we are woefully unknowledgeable in many of these things and what's causing them and why and what we can do about it. But usually with these sort of diseases, there's autoantibodies that are causing the damage and the pain and whatnot. And so the mechanism of action of LDRT is very similar to, it's an anti-inflammatory like ibuprofen or prednisone. It's just a different pathway. So, just like, well, you wouldn't have ibuprofen as first line for psoriatic or psoriasis or rheumatoid. You wouldn't do this either. But as time goes on, depending, these are usually kind of lifelong issues. As time goes on, the chronic sort of wear and tear and inflammation generally turns them into a version of osteoarthritis, and at which point I do give the LDRT. So usually what it is if somebody brings this up to me, because as also in America, and this is true I think across the board, people remember the the managed care era and think that they can only come to us if they have a referral. And I have people just call my clinic and ask for an appointment. So you don't need a referral for this. So usually how this conversation goes is a staff member or a patient or a friend or a family member says, hey, I have so-and-so, they have really bad rheumatoid arthritis, can they come and see you? And then I usually ask, like, well, how old are they and how long have they had it? And then we kind of go from there. So it's usually people in their 50s and 60s who have had it for a long time. They usually have a lot of joints that are painful, but there's usually some specific ones that are more painful than others. And if they've had it for 10, 20, 30 years, there's usually very much a degenerative inflammatory component to it. And so that's what I focus on is, in these people who have these diseases, is there a specific joint? Is it long standing? And so like recently I did this with someone with a rheumatoid, and her thumb was the most painful. And so while she had several joints that had pain, the only one that really had clear degenerative inflammatory signs, and she had x-rays and stuff, was the thumb. And so we treated the thumb, and will not be planning on treating in the near future of the other joints, but that might come up. So it's usually just kind of picking on that, because it's just like ibuprofen and prednisone are sort of agnostic as to why there's inflammation or pain. Same with this. And so, it's a painful degenerative inflammatory joint, just so happens to be from psoriatic arthritis, but at the end, it's kind of the same thing. And so I view it as such.
Okay. Thank you. Next question. What about the risk of bone loss due to radiation as a possible side effect of LDRT?
I think this question and questions in this vein, so in the podcast, I like to use in real life, I like to use the analogy of the bike and the plane. So if you think about radiation, you think about gray or dose as miles per hour. So an airplane has to fly at certain miles per hour. A bicycle has to drive at certain miles per hour. If you take a bike at the airplane speed, you're going to have a bad time. If you take the plane at the bike speed, you're going to have a bad time. And so the questions of this sort, or concerns, are more in the context of you're used to us doing 60 gray, 70 gray, and they're absolutely sort of a concern in that context. Paradoxically or interestingly, the in vitro and preclinical data has shown a lot of evidence that low-dose radiation actually improves bone strength. And so I mentioned this specifically, and I think I linked this in one of the earlier episodes, but there's a 2023 review paper on a lot of the laboratory evidence for this, with Lisa DeLocke as the senior author on it. And it has a section on this where there have been studies where there was like in animal models, so preclinical models, they had fractures in rat femurs, and that when you apply low-dose radiation to these fractures, it actually heals significantly faster than without low-dose radiation. There's another paper I can link probably in the follow-up episode to this, where it's usually stimulation of osteoblasts, inhibition of osteoclasts. One of them is about kind of altering the callus formation and kind of the steering the sort of microenvironment into a more pro-healing pathway. And this is all, to my knowledge, no one has ever tested this out clinically, which that's going to be a tough sell, but, it would be very interesting if you had a clinic where you had sports injuries and people were breaking bones and you just gave them some low-dose radiation. So to my knowledge, this is all sort of in vitro and in vivo, which is very interesting, because a big knock on the people who are unfamiliar with this is, oh, there's not enough data, there's not enough evidence, or how does it work? When really there's an absolutely overwhelming amount of evidence, just they haven't gone to PubMed. And in that evidence, it's a lot on how using the radiation at this dose and this pathway can actually promote a healing environment.
Okay, thank you. Also, just a quick housekeeping item for those of you who may have joined us late. Just a reminder that this is a moderated Q&A, so if you do have questions, go ahead and submit questions using the question section of the GoToWebinar control panel. These questions were pre-submitted, if you will, by people who registered early. So go ahead and ask questions, and I'll moderate those for Dr. Beckta as we move forward. Next question, are there any data that you're aware of or any preclinical data to suggest a biological difference between the impact of 200 kV radiation to 3 gray versus a 6 MV Linac regarding clinical outcomes for patients with OA?
So I think, and this one I definitely have to put in the next episode. So there's at least one paper that is out there where they compared this, and so it's interesting because, and you have to, for those of us in America who took physics boards during residency, it goes back into the bone absorption of the 200 kV versus the MV, the dose, and so usually we're worried about that in terms of hot spots and cold spots, and not like a lot of people got the advantage of using ortho voltage, or at least seeing it in residency, because they kind of have not been used as much lately. But so I think there's at least one paper that showed that there was actually improved outcomes with the ortho voltage levels of radiation compared to the photons. And so a lament of mine is that I don't speak German, and a lot of these papers are in German. And so, but now we have ChatGPT. So I'm literally trying to get ChatGPT to translate a German thesis on this topic. It crashes every time I do it. I don't know, I have to pay OpenAI more to get that to happen. But so, this is the one thing that's incredibly interesting, because usually we're concerned about the bone absorption in orthovoltage in terms of, dose homogeneity or whatnot, if you're talking about for the, the 100 kV stuff and for skin and whatnot, and if you're kind of right over a bony prominence and not. But in this case, it's actually preferable. So I think this is an area where there could be more work done in general, but I think there's at least one, and I'll try to follow up on that with the next step with the follow-up episode.
Okay, thank you. Next question. What OA randomized clinical trials would you like to see conducted in North America, or for that matter, anywhere?
Whichever one gets the KOLs to endorse this. So, it depends on how you're asking this question, and I'm using a royal U because this question I think is pretty common. So number one, again, it presupposes a lack of evidence, and as I've kind of hit repeatedly in the podcast, the first time low-dose radiation or radiation in general was used for inflammatory degenerative disorders was 1898. So it was 1898 in Europe and 1906 in America. And so we literally have 125 years of usage for this, and a lot of it has been published. So if you go into the literature, there's like tens of thousands of published patient experiences with it, and most of them were largely positive. And so I think the attitude in America we see, and I've seen it turn around pretty rapidly from when we did that Red Journal article in 2022 with the Vanderbilt crew to now. There's been a lot more talk. I mean, the Astro newsletter thing just came out last week, and that was all on benign conditions, including this. And so I think for the last 20 years in America, there was just a general ignorance of it. And so it was just very dogmatic reflex of, oh, I didn't hear about this in residency, so it must not have evidence. But if you go back to the spring refresher courses from 20 years ago, this was actually part of it, where there was a benign section in spring refreshers. So it's to quote my favorite character from True Detective, "A time is a flat circle." So the issue is a lot of people are just not aware, and so that was kind of where this comes from, where the podcast comes from, where all the other activities comes from. It's just like reminding people that you can just go to PubMed and search these things, and you could find everything I'm talking about. And so, in terms of what randomized controlled trials are left to be done, one, all of them, because science never ends, but two, I think so like in the most recent episode, my concerns about the recent Dutch ones that were negative and the design flaws within those, I think redoing those sorts of trials with 0.5 gray instead of 1 gray, with a repeat course at 12 weeks instead of no repeat course, with a much more reasonable statistical design and outcomes measures, just basically doing what they did, but, better. And because then some of these other trials I'm worried about is with, I think the Lord Nira trial, the Korean one, I'm not sure that, I think they use 0.33 gray as their control arm. To me, I think 0.33 gray is actually still an intervention. So if you go into the literature for these, and especially in the in vitro stuff, it's not inconceivable that that is still going to have an effect. Like at the end of the day, is still ionizing radiation. Like yes, 0.33 gray is shockingly low compared to our normal, you know, we're doing 70 gray or when you're doing 3 fraction SBRT or whatnot. But I am not sure that that's a true control arm. I think that that might muddy the waters where, and so, you know, I'll have to double check. I could be wrong in the dose, but because if you look at like the Alzheimer's data, so in the case report that came out of Canada, for those who don't know, there was, I think, at least 2 papers now. So there was a Canadian experience where a Canadian radiation oncologist, his wife had Alzheimer's disease. And so they noticed that with repeat head CTs that she actually had improvement in Alzheimer's. So if the dose from a CT scan is enough to see, now again, case series, and there was just that red journal article that came out of VCU doing the clinical trial in Alzheimer's, but more conventionally. But, you know, if you're theoretically seeing improvement from just a diagnostic CAT scan, that to me says we really have to be very thoughtful about what we choose as our controls. And I think a true sham, and one of the other trials from I can't remember where, but they played Linac sounds, or you know, as the machine whirled around. So it was a true sham. There was no radiation. I think that's the number one thing. But really, it's just got to be whatever trials and whatever institutions and whatever design that gets people over the, you know, dogmatic paradigm hump of saying, no, you know, this isn't real or this is placebo or whatnot, and just mostly out of ignorance or unwillingness to look at the data or consider that maybe there's been this entire space that we've ignored for 20 years or 100 years, you know, depending on who you talk to. So.
Okay, next question now coming in from the group that we have on the line today. It's not specific to OA, but the question is there any benefit of orthovoltage radiotherapy for heterotopic ossification? The attendee notes that their orthopedic surgeons are questioning us for elbow intra-articular fractures as primary prevention.
Oh, interesting. Well, so because originally, whenever I hear heterotopic ossification, my mind immediately goes to hip because that's always my go-to. So I am not aware of orthovoltage specifically for HO in terms of has that question been specifically addressed. I would say that I don't know mechanistically why there would be a problem with orthovoltage for HO prophylaxis versus Linac, except in the size of the patient, the body part, and the strength of the machine. So for an elbow, you know, I think I don't see why for elbow HO prophylaxis, I don't see why an orthovoltage would be, you know, at least just as effective as a linear accelerator. The concern I always have for orthovoltage for anything is when you're talking about the hip. So, you know, especially with the 200 kVp devices, 200 kV for most sized humans, for most joints of the body will get you there. The hip is probably the most problematic simply because, especially in America, body habitus can be quite large in that area. And so you might not get the penetration in the hip region. And so that would be true for HO prophylaxis or for, you know, OA or for anything. So for an elbow, I think it would be fine. I'll have to look because I haven't seen that, but it's a good question, but I don't see why the elbow wouldn't work.
Okay, next question, you know, it's sort of taking us back here to the one on the screen regarding the randomized clinical trials and your comment that sort of anything that'll keep this moving forward. Specifically on the studies coming out of the Dutch group, you had commented on the protocol, the sort of 6 kV over 6 fractions versus what you're doing, 3 kV over 6 fractions with typically that second course of treatment. Can you comment on how often you are doing that second course of treatment, and is the sort of 3 kV, 6 kV the difference between the sort of, you know, the bicycle and the tricycle, to keep your airplane bike metaphor going?
I like that, the tricycle. So I think you mean gray, right? 3 gray versus 6 gray.
Yeah.
Yeah. So.
Oh, my bad. Yes, 3 gray versus 6 gray.
Yeah, that was a very physics-driven question. I like that, KB. So yeah, so where that comes from. So I guess point one about retreatment. So in my experience, it's hard to get a beat on it. So all right, the way in real life this works for me is that I will do the first treatment, then I will have the patients come back at 12 weeks, and so this is the weird part, is that people I mean, we're all trained to think like we want immediate results, and we're used to that. Like when you have a headache and you take ibuprofen, your headache feels better in general. So that's how people usually expect it. And so it's more similar to like when you're trying to counsel a patient on pain relief from bone mets, but even longer. So the number one thing is I look for on, so you get about maybe 10 in the literature, you'll see maybe 10 to 20%, but I see maybe 30 to 40. You'll see some people tell you before the end of treatment that they have pain improvement. It's not, I never expect it. I never even bring it up basically, but you will see some level of patients that have some improvement. However, you also see some level of patients that will have pain worsening. And to me, and this is what I tell the patients, as long as something changes, I think that's a good prognostic sign. So usually what I see more is a pain flare almost. So people get really, the nurse will come give me and say, hey, so-and-so was attacked to you because their pain is worse, blah, 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 and the patient will be upset. And I actually view that. So for whatever reason, I think I've seen this talked about a few places, but I don't think this has ever been formally studied. So I am really encouraged whenever I get like a pain flare. And so, because it means something is happening, the joint is responding. And so, usually it's kind of in that area, but regardless, I bring them back at 12 weeks. And so I'd say, look, no matter what you're experiencing now, you got to give it time, and not even 4 weeks is enough. Not even 6 weeks is enough, 12 weeks. And so when I bring them in, now my preference, if I were in absolute control, is if they got decent amounts of relief, I want to save that second treatment. I would prefer that because there are people out there who will do like a third course and stuff, but once you get into that level, you start to break that magic or hit that magic 10 gray threshold where you can see some of the late effects more. And so I like to have a backup plan kind of guy, and this is how I live my life. And so if they tell me they've got like 70% pain improvement or whatnot, I will be like, can we just maybe hold off, and you'll call me if it comes back. A lot of people will agree. I definitely have people. I just had a woman that I treated her lower back, and she got 80% improvement, and I say, great, let's hold this one. And she said, no, I want 100% pain improvement. And so it was important there. So we did it, and it worked. But I would have, if I had a magic wand, I would not have done that. But so all that being said, is that second course is a game time decision. It's really like a clinical presentation, and it's a discussion between you and the patient and goals and whatnot. And so for me, I would say, I actually rather infrequently do this. I would say maybe less than 50% will get that second course. Now, is that me? Is it my, what I'm doing or my patient population? I don't know. But it's, in the literature is definitely important. So when you see the most common cited thing is like 80% of people will get, relief from LDRT, that 80% comes from all comers, meaning people who got 1 or 2. So I would say in my personal practice, less than 50%, but how much of that is me, I don't know. In terms of the 3 gray versus the 6 gray, that's very much driven. I mean, anecdotally, I did the 6 gray once. I don't like it. It didn't work. I'll never do it again. But so that's anecdote. It doesn't count. But in the in vitro stuff, in the in vitro and the in vivo data, a lot of it has shown very clearly that the 0.5 gray is superior to the 1 gray. And I think once you get up into the 1 gray, that's where you start really activating traditional sort of DNA damage responses and apoptosis and so on and so forth. And so I think now the question is, what is the lower limit? Again, going back to 0.33 is not a control. I think with diagnostic exams, I would argue maybe even down to 0.1 or 0.05. At the end of the day, you're still sending ionizing radiation into a human being. You might think it's very laughably low, like homeopathic type dose, but it's still ionizing radiation going into a human that would not be happening otherwise. So, I think from the in vitro, in vivo, preclinical, and clinical data, without question, the most positive benefits come from 0.5 gray. And as time goes on, we might see that it can be done lower, but time will tell.
Okay. Next question from the audience is around the billing episode. The attendee just comments how much he really enjoyed the billing episode, and again, that is a great one. If you haven't heard that one, for all of you online here, I would strongly encourage you to go back and listen to that. The attendee notes that you were very focused on MV machines, which you're currently using, but he would like to know more about orthovoltage billing. And you're very specific in the mini series to note that you're not planning to go into a lot of detail about orthovoltage systems, because you know, you feel like there are a lot of people out there that can speak more confidently about, you know, that subject matter. However, in the spirit of this live Q&A, is there anything that you could discuss around reimbursement and supervision that you're maybe familiar with some of your colleagues who you know, you do note in the podcast that you know that this is happening, you know, in the United States on orthovoltage units. For instance, the attendee asks how many patients would you need to be treated monthly, you know, to kind of, from your view, to kind of be breaking even on one of those orthovoltage units?
I have the checklist, so interesting if supervision is brought up there. That's my other favorite topic, as many people may know. But I to be clear, I can answer those questions very precisely, and I refuse. The reason being that, you know, what I have learned over the years is that what I do here in Vermont might not work in Georgia, might not work in California. And so it's mostly, that's the issue, is that this is not, it's well known among your administrators, I promise you, the people who own your hospitals and your machines know this very well. But among the clinicians, the nuance that actually goes behind, we talk about these things in very broad strokes of, like, going back to supervision, like, you know, just talking about director general supervision as if you can just win. America's a very big place, and to just say, oh, we'll have this sweeping sort of regulation it'll work great for everyone, like, that's not how this country works. So the issue with the billing, or why I wasn't specific, is that it really is geography dependent. And so but to be more specific about orthovoltage, you would bill it just like you would bill anything else. So there's confusion. I've seen this more maybe in, like, insurance companies and things. None of the radiotherapy codes are specific to cancer. If you ever hear that from an insurance company, they're wrong. They're wrong. So, like, the 77 codes are not, they're you know, disease process agnostic. They're simply about radiotherapy delivery. So if anyone ever tells you that, they're wrong. So however you would bill in orthovoltage, and if you go, and I think it's like 77307, I can't remember, it's either 77307 or 77407 or one of those, but you just open up, you know, there's a couple of the billing resources you can find, and you would bill this treatment just like you would bill for a bone met. So there's literally no difference. And there is, again, just to really drive home that none of these codes are specific to cancer. You do have to use the arthritis specific ICD codes, the ICD-10 codes. So they're all in the M codes. And so that's just like you use a D code for DCIS instead of a C code. You know, you do have to go into the M codes, and you just specifically pick, you know, like M17 dot something for knee. And I have learned subsequently, so I love using like M1990, which is unspecified, and that does get rejected now, so that might be on me. But so be very specific about that, but bill them just like you would. Now, in terms of what is the cost to break even, so, you know, it's very interesting in terms of your workflow and your patient population. So number one, I think the size of the potential patients you could treat is so overwhelming. If all you know is cancer, it's hard to even, you know, think about. So we are very used to kind of our patient population being just the cancer patients, and of those, just the cancer patients who are eligible for radiation. That is a very niche number of people. We think that there's a lot, and there's a lot in a certain sense, but that is incredibly small. Comparatively, if, you know, I would estimate, well, I would steal other people's estimates, that there's maybe 30 to 50 million Americans with osteoarthritis right now. So we're just osteoarthritis. All the others, so I just saw that cool emphysema SBRT paper that came out of the Red Journal. So like in all of the blanket of benign, but like in just osteoarthritis, we're talking 30 to 50 million. But, you know, how many joints are there in the human body? So even we're just talking about 30 or 50 million, most of the people I treat have more than one painful joint. And so the volume is huge, and it just becomes a numbers game to a degree. So yes, you know, the reimbursement for orthovoltage is generally less than linear accelerators by Medicare dollars. Medicare dollars are sort of fake, where, you know, most people make money off of the private insurance contracts. So it just, you know, the CMS numbers are used because that's just, they're easy to do and they can be done. But the, you know, how good are you at negotiating your private payer contracts? That's number 1, 2, and 3. How good are you at billing? Like, what's your, you know, AR time? Like, are you getting things done in like 30 days, or, you know, what's your clean claims rate? Like, so a lot of it depends on you and your billing company and how good you are at it. So, you know, using Medicare rates I haven't looked at this in a bit, but you know, and then do you need to build a new facility? Like, can you drop an ortho voltage device in an existing space, or do you need to build a new clinic? So like, you know, just dropping in, if you have a room, you can put an ortho voltage in. You know, you're talking, you could probably have an ROI of like in less than 6 months, but that is using Medicare dollars. So then, because the ortho voltage devices in particular are a lot less expensive than the linear accelerators, it does open up, like, is there such a thing as, you know, almost like a concierge sort of radiation oncology? Could you do a cash pay type thing? Because you know, as I've gone to saying on the podcast, things like Medicare Advantage are going to kill this country. And so we're kind of approaching this point where, at what point, even for radiation oncology or for all of medicine, like, is sort of the insurance world, what we're seeing right now, how long is that sustainable for? And, you know, do we need to think about these things? But, you know, it does require sort of a mind shift. And so if you're like a new grad, or if you've been like a W-2 employed rad onc only doing cancer for your whole career, you know, it requires a level of savvy that you're not going to get exposed to, or like knowledge and experience and things. If you are a private practice like person with, you know, you own their machine or you have technical buy-in, like you're gonna, well, one, you don't need to listen to me for sure, but you know, you're gonna be able to pull that off. But it is definitely doable. It's just the skills and the mindset are in the vast minority right now. But yeah, so it's mostly, but the main one is just, you would bill it like you would 6 fractions of anything else.
Okay. Next question is around, you know, the patient experience. In the episode, you cited, you know, a possible barrier to overcome for patients choosing, you know, to move ahead with LDRT as the number of visits, possibly, you know, and the sort of getting the mobility and kind of getting up on the table. Can you speak specifically? Have you had a patient decide not to do a course of LDRT for these reasons, or is it, you know, how big of a factor is this in terms of patient acceptance?
Yeah, no. So I guess there's two parts. I'm trying to remember. If I said that, I must have brought that up earlier, because I recently mentioned it in the phase 3 or the RCT stuff from the Netherlands, because they powered their trials so crazily because they felt like it was so onerous to come in for 6 treatments that the only way it was worth it is if they saw this tremendously insane benefit. So, which I think is bad and wrong, and that was part of the problem with that trial. But because it is ultimately, you know, 6 treatments plus, you know, the sim, it's less than a dozen treatments by far. It's less than 10 treatments, or less than 10 visits, I should say, including consult and stuff. So I haven't had any. It's the exact same as any other of our patients getting on and off the table. So, you know, it's as long, really, in my experience, the only time it becomes prohibitively difficult is when a Hoyer lift is involved, which I have not done for LDRT. I'm trying to think. Yeah. So that's because then, you know, most of us don't keep Hoyer lifts down in our department. The therapists don't love using Hoyer lifts, and so on and so forth. I have not had a patient unable to do the treatment because of mobility issues. I'm sure it would happen at some point, but it's functional. It's no different than any of our other patients.
Okay. Next question. How often are you performing and billing for a simple simulation over a standard 6 fraction treatment? And, you know, he says he also means to ask about dosimetry too. So if you could comment specifically on dosimetry also.
Yeah, so I bill the same. So basically, you know, I always do a sim, and so literally, the easiest way then to think about this would be, imagine you're doing a bone met and you're doing 6 fractions for a bone met. It's the exact same. So I don't do the weird. I know Derm in Derm Rads is doing their, you know, build a simple sim with each fraction. I don't do that, and so I do it. It's literally, if you gave me a 6 fraction bone met, 6 fraction LDRT for osteoarthritis, I would build them the exact same. And so by that I mean, if I've often left the setups to the therapist with what they think works best, which has kind of worked out good for me too. So like they like to use a VAC lock a lot. So a VAC lock is a 77334 charge. It's still a complex treatment device. It's still the same charge. So again, everything is the same. Just if you think of it like a 6 fraction bone met. In terms of dosimetry, it depends on your dosimetrist. It depends on your physicist. It depends on the machines in your TPS and stuff. And so, you know, usually if you're talking about a linear accelerator, we're talking about just standard sort of 6 MV beams. I always try to do like a version of APPA. I just try to keep it as simple as possible. So it's usually 6 MVs, it's usually APPA or a version thereof. Currently, we have Easy Fluence here, which is the Reformation product. My dosimetrist loves using Easy Fluence for everything because it's fun and a lot easier. So yeah, really, we approach it the exact same way as a bone vet, basically, and bill it, plan it, and do it pretty much the exact same way.
Okay. Regarding the therapist support that you have, I did just a follow-up question, because in that, in the podcast mini series, you also mentioned, sort of letting the therapist do what they do best, right? Have they shared with you anything in terms of the, kind of traditional accessories that they have for cancer patients? Do you, kind of looking ahead, do you think there's any advancements that could be made with set of accessories to facilitate LDRT treatments for things like OA?
Yeah, it's very interesting, because what I discovered when I started doing this was that we really don't do much extremities. So, for the most part, we are head and neck, thorax, abdomen, pelvis. That is the majority of what we do. And unless you are one of the rare sarcoma specialists, you quickly realize that, oh, you don't do this a lot. Now, I don't do it as much here, but in my prior practice, I did a lot of skin. So I had to get really creative with like various skin setups. So my favorite is standing with your hand in a machine for electron treatments for skin. I don't do that for this, but I'm a big fan. I once treated on a stretcher, but it's a story for another time. But so it's mostly, interestingly, the one thing I wish is that we had wider tables. But then we get into the limitation of pore size on the CT simulator. But yeah, I think it's mostly being cognizant of your likely limited experience in extremities and adapting thereof. And so the one thing I think I wish I think all of us, and myself included, are using like the Aquaplast masks for hands a lot. There are other hand immobilizer type things that I've looked at or sketched out for maybe in a future when I have, invent a 36-hour day, I can work on developing that. But yeah, I think the main thing I wish is that we had kind of better setups for hands, because otherwise, with legs, at least you can do backlocks, you can do the cradles, but hands, it's because you run into a couple issues. One, sometimes, especially with this patient population, they might have issues with extending their arms above their head. So I prefer to usually do prone on a triangular pillow with the hands under the Aquaplast mask, which is great if you could tolerate that. But that's not always. So sometimes, like, I'll do not even like an arms akimbo, but if you have somebody supine with arms at their side and you kick their arm out enough so it's not falling off the table, but you get separation from the body. But yeah, that's kind of been the most interesting challenge, is mobility as it relates to treating the hands. Yeah.
Okay, next question, kind of back to volume loss on the bone mass. What is the difference between experimental and investigational levels of evidence around this, and what is the nomenclature for the level above this?
It depends on who is writing it. So it's all, yeah. So this is the issue, is like, there's some insurance companies that get really hung up on these words. And so I think so going back to the 2022 regional article where Austin Dove is the first author on that. So we use that in there, but it's mostly out of caution. It's about kind of being good citizens of science. And so, every single paper, if any of us who have ever read any papers, if you go find, there should be zero. I bet there are some. There are very few papers that don't end with more study is needed, or whatever insert language here. I think that the dogma of American medicine has been very harmful in this, and the conversation around this has been very harmful in terms of acceptance by both patients and clinicians and payers. And so to my knowledge, there may be some goofy organization has some official definition for what is experimental versus what is investigational. In the papers that I am on, if and when we use those words, they were included there because it worked in the flow and clarity of the prose, and not because we pulled up the WHO manual and we thought, this is experimental, this is investigational, that's not real. So it really just is, beauty is in the eye of the beholder. And so to me, and that's why I hate this so much, it's, we use those language because it's the responsible thing to do. And I would say, if anyone ever tells you they figured out something completely in any subject, it could be astronomy, it could be mathematics, it could be this, that's not true. Like, we're not that smart. It's, we're going to be doing this for as long as humanity is on this planet. So, everything is experimental, everything is investigational. I would argue, the opera trial for rectal cancer is investigational. Lung SBRT is investigational. Head and neck radiation is investigational. We're still talking about, should we do 30 gray? What kind of chemo should we use? Everything is investigational. Everything is experimental. I would argue that this is the oldest thing that we have, that if you go back 125 years, we're still using radiation, but the only thing that we're kind of similar to today is back then that we're doing is a version of this. So at what point is that century of evidence good enough? It's kind of in the eye of the beholder.
Okay. We are closing in on our time here with you today. So I did want to, ask the audience if there are any other additional questions. We probably have time for a couple more. Next one, do you administer LDRT for OA for patients below the age of 40 years old? In our practice, patients must be above 40 years old to minimize the risk of secondary malignancies, but we have had a few requests for LDRT in younger patients.
I really like this question because I don't know. So fortunately for me, this has not come up yet. Now 40 that must be maybe that's a European asking that question. So 40 is more European. I know the ones in America, a lot of people have said 50. And so it's a great question. And so because I think about this when I was in residency, what we used our orthovoltage for a lot was keloids. And so pretty frequently we would have teenagers with keloids come in, and oftentimes they'd be earlobe keloids. So then we're talking about, okay, and you go for a higher dose for keloids than you do for OA. And so, you're counseling these teenagers on risk of like meningioma, basically, or kind of, you're talking about earlobe keloid radiation, orthovoltage or not. And, it's a risk versus benefit. Sometimes I've wondered, because a keloid could be very damaging for quality of life, but is a 1 centimeter keloid on an earlobe for a 14-year-old, is that different than a 37-year-old with near debilitating knee arthritis? And then going back to the other things about what is really the risk of secondary malignancy, where this appears to be, as I'm very fond of saying, there is no good evidence. There's basically no evidence. There's one piece of bad evidence that there's any form of secondary malignancy if you keep it under, I would say 10 gray, but certainly below 8 gray. So even if you're doing both courses, there's no recorded evidence of a secondary malignancy from 6 gray or less. And it's a game time decision. If you put in front of me a 35-year-old person who says that, who is having a conversation with orthopedic surgery about a knee replacement, like that's how bad it is. They've tried everything, physical therapy, and now they're at the point of knee replacement, I would absolutely treat that person. But that's a game time decision. And so, it's really risk versus benefit for this as it is for anything else.
Okay, next question. Coming from someone who has not had any experience with KV X-rays, can you comment on how you would choose beam energy for orthovoltage treatments? I know you're currently treating with a LINAC. Do you have anything here?
Yeah, so that one, the only thing I would say is it's really based on the depth dose curve. So, make sure your physicist refresh. If they aren't used to this, make sure that your physicist, brushes up on it. And those are the classic sort of curves that you will see everywhere. For the most part, the energies around the 200 kV will get you most to most joints. Again, the hip is the only questionable one. But a 200 kV or 180 or 220, around that, they can dial it in kind of that. So between 180 and 220 kV will get you to where you need to go. You do generally need to do a slightly higher dose. So this is me talking from secondary experience. But so instead of like saying you're going to a total dose of like 3 gray, like you would for a 6 MV LINAC, you might need to prescribe like 4 gray or like 3.6 gray to account for you're trying, because you're prescribing basically to mid plane. If people remember when that used to happen, I've read that from books. I've never been alive for that. So, but so you want to get what's important is the dose at depth. And so usually with around a 200 kV energy, you need to prescribe to slightly higher doses to get that 0.5 gray at depth. But.
Okay, and final question, is this treatment currently offered in the US? I know that you do comment on that in your podcast. Maybe you could speak to, you know, do you think this is a few folks, more people than we realize, or do you think this is more common than we probably even appreciate?
I think it's changed very rapidly. So when I started doing this and when that came out, so like 2 or 3 years ago, I was only aware of a handful of practices doing it. And then as just even this year, actually today, I've got 2 texts from people who are doing, actually, sorry, to be more precise, yesterday afternoon and this morning, there were 2 different people in different parts of the country that contacted me saying they're planning their very first cases. And so, you know, I've witnessed this change so rapidly that I think it's more common than it's more common than I realized, put it like that. Now, the issue is what I come across a lot is people know I do this. So then I will get asked, hey, I've got a friend living in Montana. Who would you send them to? And I have no idea. So that's kind of the bigger problem right now is that, you know, it's people want to do it. Which is drove the podcast, drove this webinar, drove all these other things that's getting it out there. I'm heartened, and I would think that you wouldn't see this level of rapid adoption if this was all BS. Like if this was fake, if this was all placebo, if this didn't work. So like I say in the podcast, I don't advertise at all. I have never, ever advertised because I would die. Like I would just be totally overwhelmed. All my OA patients come from word of mouth. So you know, from my own follow-ups is when I started doing it, then they tell their friends and family and we treat staff members and things. So I have never, ever tried to build this at all. It is all word of mouth. So if you see this rapid adoption, and if I see my patient population only just comes from word of mouth, to me, you know, that's the best trial evidence that you possibly could, because that, you know, maybe it's all made up. You know, that'd be pretty wild, but I guess crazier things have happened. But yeah, so I think it is really being rapidly done, especially with Astro jumping on board and publishing that. I think that dipping now, because Astro I think forgets that 20 years ago they did their spring refresher, but I think that really speaks to kind of sort of remembering things that used to happen and remembering that, oh yeah, you know, this is the thing, and oh yeah, Germany does do 50,000 people a year, and oh yeah, you know. Yeah, so hopefully it'll be more and more, and then I won't have to stutter and stammer when somebody asks me who in Montana I recommend. I don't
know. Okay, thank you. And just for the audience, Dr. Beckta is referring to the latest issue of the Astro News, which came out in early April, which has a number of articles dedicated to the use of radiation therapy for benign conditions, including Dupuytren's, for example. So, on behalf of Xstrahl, Dr. Beckta, I'd like to thank you again for supporting this mini-series and for taking time out of your practice today to answer questions from the audience. If we did not get a chance to get to your question, we will follow up. And as I noted at the beginning, Dr. Beckta will also be recording a final episode of the mini-series on reflections from today, and also including some of the literature that he, you know, we discussed earlier, particularly that study around KV versus MV, the study outside of Germany. So again, on behalf of Xstrahl, thank you so much for attending today. And with that, I will close today's session. Thank you again, Dr. Beckta.
Thank you, guys.